Okay, please proceed.
Hi, Prof. You're speaking to Cara Libber and also Cara Dorning. So we're both here together. Today we'll be presenting contraception and pap smear. So we'll start with contraception. I just put in a small quote that said, a girl should be two things, who and what she wants. And I said that because when we give women education and access to contraceptives, we place family planning and safety against STIs in their hands, which allows them to be empowered.
Okay, so I will be discussing the types of contraception today. There are many ways to categorize types of contraception. We decided to use three main categories: the barrier method, non-hormonal methods, and hormonal methods. And then we'll later mention a subcategory of long-acting reversible contraception. So barrier methods are quite common in our setting. The most common one, I think, is the male condom. We also get female condoms, which aren't very widely available. It's also a bit more difficult to use. The diaphragm, and then spermicides. Spermicides are then the least effective of the barrier methods. So why are we so focused on barrier contraception? And I think why it is so popular is inexpensive and easy to obtain. They have few to no side effects. And the male condom specifically is the only method that we have that is protective against STIs as well. There are some allergies when it comes to, or adverse reactions when it comes to barrier contraception. Very uncommon is a latex allergy to condoms. And then the spermicides sometimes have vaginal irritation and an increased risk of UTIs. So we've decided to focus on the male condom when we discuss barrier contraception. It can be very effective if it's used correctly and consistently. Its mode of action is that it acts as a physical barrier to the sperm entering the female genital tract. However, its efficacy can be compromised if it interacts with oil-based lubricants or vaginal or rectal creams. The big thing about a male condom is that it prevents the transmission of STIs via bodily fluids. Just to remember that it is somewhat less effective against STIs transmitted via skin-to-skin contact, like HSV and HPV. So non-hormonal methods, we are looking at abstention. That is pretty much self-explanatory. It's not engaging in sexual activity, and then avoidance of sexual intercourse, and they will just counsel the patients on what that entails. Then the withdrawal method, or also known as coitus interruptus. This requires the removal of the penis from the vagina and away from the external genitalia prior to ejaculation, then preventing the sperm from entering the genital tract. It is an old method that's been used for many years, but it does require the patient to be motivated and used correctly and consistently. Otherwise, it's not a very good way of contraception. Then with fertility awareness, there's two mechanisms that we just like to discuss. The one is the fertility awareness-based method, where you avoid having sex during the fertile period. That involves the calendar method, standard days method, ovulation method, as well as the lactational amenorrhea. I think we try to avoid this when we counsel patients because it needs a lot of education, and language barriers can always be an option, and it can actually lead to not very good contraception at all. Then we'll just later in more detail discuss the other IUCDs, the intrauterine contraceptive devices, but the most common non-hormonal method is the copper T, which creates an increase of leukocytes, macrophages, and prostaglandins in the uterus tubes, and then it kind of acts as, it damages sperm and ova, preventing fertilization any further. Then we're just quickly going to discuss sterilization. I didn't go into much detail here because it's not the first thing we offer patients at a primary healthcare level, but it can be male or female sterilization. And if we get to that point, I think it's best to refer patients and they need counseling with regards to that. In the non-hormonal methods, we are discussing the copper IUCD in detail as it's available in our setting. It's very effective, up to 99% in the first year of use. It acts as preventing fertilization by inhibiting sperm migration, as we discussed earlier. And then also it changes the endometrial lining. So that also then secondarily prevents implantation of the sperm. It is contraindicated in someone who's already has heavy menstrual bleeding, active pelvic inflammatory disease, purulent cervicitis, unexplained uterine bleeding, any uterine or cervical CA, and other uterine abnormalities. Women quite commonly complain of having heavier and more painful periods with the copper IUCD inserted. The nice thing about it is it doesn't really have any drug interactions. It, however, then, unlike the male condom, doesn't protect us against any STIs or HIV. Then we're going to move on to hormonal contraceptives. Here are the 4 categories we're discussing today: the oral contraceptive, the hormonal intrauterine devices, the injectables, and then the implants. So an important thing to just keep in the back of your mind when it comes to especially hormonal contraception is the medical eligibility criteria for contraceptive use. This offers guidance on the safety and use of different methods of contraceptives for patients with specific characteristics or any known medical conditions. There's a very nice app on most app stores available. It's freely accessible. It's created by the WHO, and you can type in a few of the patient's conditions, and it tells you under what category the patient lies, and then what different contraceptives are better to use, what contraceptives are better to use in a patient that are at high risk of using a certain contraception. So the oral contraceptives, the 2 main ones we're discussing today, which we all know, is the combined oral contraceptive. It has different concentrations of estrogen and synthetic progestogens. Commonly available in our setting is Trifasal, Nordet, and Overall. And then the progestogen-only pills are estrogen-free, and they contain low doses of synthetic progestogens. And we have norethisterone available. So our combined oral contraceptives can be very effective if it's used correctly and consistently. We'll later discuss how to correct for missed pills, because that can influence the effectiveness of the COC. It prevents ovulation, and it also has other mechanisms that are being speculated about. We must remember the contraindications. It's got quite a high side effect profile. Because of the increased estrogen in the COC, it increases the clotting factors in the blood, and then can lead to being hypercoagulable, and is thus contraindicated in current or previous history of venous thromboembolisms, ischemic heart disease, strokes, migraines, antiphospholipid syndrome, and it also interacts with other drugs that we'll discuss a bit later. It has some side effects: nausea, it has intramenstrual bleeding, it can cause some headaches, migraines, and breast tenderness. Important to remember with the combined oral contraceptives is it does have quite a few interactions with other drugs. It decreases the concentrations of some anticonvulsants. In our setting, also important to remember rifampicin. It decreases the concentration of rifampicin. I know we always say we tell the patients to use an additional contraceptives when you give them antibiotics, but there isn't actually very strong evidence recently that suggests that is the case. Also important to remember in people taking ARVs, if they're on any protease inhibitors, it also decreases the efficacy of the oral contraceptive. Then the missed pill, I think this is something that patients can come, to us and say they've missed a pill. What do they do? This is just a quick diagram to sum it up. If the pill has been missed more than 24 hours and up to 48 hours late, the missed pill should be taken as soon as it's remembered, and the remaining pills should be continued at the usual time. When it's more than 2 days or more than 48 hours late, which means more than 2 pills late, the most recent missed pill should be taken as soon as possible, and then the rest of the missed pills should be discarded. The remaining pills should be continued at the usual time. And then condoms should be used as additional contraception, or sex must be avoided until 7 consecutive days of the active pills have been taken. And then just, I'm not going to go through it all, but just to remember for the patients to abstain a certain amount of time to minimize the risk of pregnancy when the pills are missed during a certain time of the period. Then the progesterone-only contraceptives. The good thing about this contraception is it can be used in breastfeeding women. It is safe to use in breastfeeding. It primarily thickens the cervical mucus and thus preventing sperm penetration. It's contraindicated in people with hepatic impairment, liver tumors, severe diabetes with vascular changes, severe hypertension, current thromboembolic disease, breast and endometrial CAs, and porphyria. Common side effects is it changes the menstrual bleeding. Can also have breast tenderness and mood changes, as with the combined oral contraception. The progesterone-only contraception doesn't have any, there's no delay in the return to fertility, as we will later discuss with the injectables that contain progesterone. Then the hormonal intrauterine contraceptive devices. We weren't 100% sure if we could find these in primary healthcare settings. I don't think we have at Mofolo. We tried to speak to the sisters there. It has a failure rate of 0.2%. It is as effective as male sterilization and more effective than female sterilization. It suppresses endometrial development and then thickens cervical mucus. It is contraindicated in most of the conditions, also as with any progesterone containing system like before, as we discussed before. It has some side effects. It can cause light irregular bleeding, infrequent bleeding, and later even amenorrhea. So the injectables, this is something that we see quite a lot in the primary healthcare setting. We've got the Depo-Provera and the Noestrate, that's commonly used in the clinics. If it's used correctly, it can be very effective. It is contraindicated in people with multiple risk factors for cardiovascular disease, and just important to remember, in young teenagers, it can cause hyperestrogenic osteoporosis. The big side effect that most women complain of is the weight gain, and that they have irregular periods, and it can also cause acne. The injectables can also interact with the anticonvulsants and the protease inhibitors in some ARV regimens. Here, it's just important to counsel the patients that it can take 4 to 6 months for fertility to return, but it has shown to have no permanent damage to fertility. Then the implanon, or the implant mechanism, we have single rod implants and then 2 rod implants in our setting. The single rod implant lasts for 3 years, and then the 2 rod implants for 5 years. It's a very good method of contraception and can offer up to 100%, is up to 100% effective. It's contraindicated in someone with unexplained vaginal bleeding and active liver disease. It's got a few side effects, also changes in your menstrual bleeding, headaches, dizziness, and mood changes, breast tenderness, and it can enlarge the ovarian follicles, which can then cause abdominal pain. Because it's also hormonal, Like the other methods mentioned, it does have drug interactions with your anti-epileptic, anti-TB, and antiretroviral drugs. It also then has no effect on STIs or any STI transmission. So we earlier mentioned that in South Africa, we focus on long-acting reversible contraception. The reason we focus on these methods is that all of them are more cost-effective than the combined oral contraceptive at 1 year of use, and the IUCDs and implants are more cost-effective than the injectable contraceptives. And then our long-acting reversible contraception that is available to us is the IUCDs, the injectables, and the implants. So something that's very important to remember, and I think something we can take home, we deal with it every day in the clinics, or at least I have, is the emergency contraception. The indications for it is any unprotected sexual intercourse, where we want to reduce the risk of pregnancy for women not using or using ineffective contraception. For example, forgotten tablets, slipped or broken condoms, injections that are more than 2 weeks late, and cases of sexual assault. We've got a few options available in our setting. The first one is the combined oral contraceptive Overall. You should tell the patient to take 2 tablets, followed by another 2 tablets 12 hours after, or levonorgestrel, 1 tablet, 0.75 milligrams, repeated 12 hours later, or you can give a stat dose of 1.5 milligrams of levonorgestrel. These methods can make the woman quite nauseous, so we can give metoclopramide to try and prevent any nausea and vomiting. The other thing that we can use as emergency contraception is the copper T. If you want to use the copper T as an emergency contraceptive, it's important to consider antibiotic cover. If the woman vomits within 2 hours of using the levonorgestrel, you need to repeat the dose. If the patient is on any enzyme inducers, like we mentioned before, the anticonvulsants, the protease inhibitors, etc., rather choose the copper T as an emergency contraceptive, or double the dose of the oral contraceptives. Women who are more than 80 kilograms in weight or have a BMI more than 30 should also receive twice the normal dose for the emergency contraception to be effective. So just going into a bit more depth with the emergency contraception, ideally you would want to use it within 5 days. I know some guidelines say within 3, but also with what we, in the South African guidelines, the latest one says that we use it within 5 days of unprotected intercourse. The levonorgestrel can be 58 to 95% protective. The overall, the combined oral contraception is less effective, but both methods are most effective within 24 hours of use. In its mode of action, as we discussed under each of them earlier, the contraindications are method specific. The big thing here is just to know that the oral contraceptions can make the patients quite nauseous and cause them to vomit. And then you need to remember that it's not only the emergency contraception, but there's also the risk of STIs and etc., other sexually transmitted infections that are not prevented by only emergency contraception. Later on, I know after the 5 days, it is still effective. You can use the copper T as a better chance of a contraception rather than the oral tablets.
Okay, so I'll be taking over from here, the other Cara. So since we're doing contraception, I just wanted to touch on termination of pregnancy. It's important for the clinicians to know and also to remind the patients that termination of pregnancy is not a form of contraception and it should never be used as that. But it should be offered to a patient that expresses an unwanted pregnancy. And when that is done, the patient needs to be adequately counseled and always treated with care and respect. The patient would then need to be referred to a district hospital. I'm not sure if clinics offer this, but the patient needs to be referred appropriately. The the healthcare worker can also refer the patient if the healthcare worker does not feel comfortable dealing with a termination of pregnancy. But again, that needs to be done with respect, and the patient should not be withheld the care in that aspect. And with that being said, we'll move on to pap smear. So the National Department of Health, South Africa, have compiled the National Guideline for Cervical Cancer Control and Management in 2017. And the goal of that was to reduce the incidence of invasive cervical cancer by implementing effective primary and secondary prevention interventions. So why is it important, and why do we need these guidelines? Cervical cancer is the second most common cancer among women in South Africa, with an incidence of 24.8 in every 100,000 women, compared to 15.8 as the global average. It's only superseded by breast cancer. In South Africa, more than 5,000 new cases are reported annually, with more than 3,000 deaths. So despite the fact that it can be successfully treated if it is detected early, the majority of cases are still detected at an advanced stage, leading to increased morbidity and mortality. So this is on pap smear, which is the secondary prevention, but we need to mention just the primary prevention, which would be targeting HPV. So primary prevention in this aspect would be preventing HPV infection by offering the HPV vaccine to all the prepubertal girls between 9 and 12 years old. And the vaccine aims to protect against HPV 16 and 18 particularly. The available vaccines that we have prevent 95% of HPV infections caused by oncogenic strains, as well as some added protection against non-oncogenic strains, which will cause warts. The vaccine rollout was initiated at schools to allow for mass coverage. And then secondary prevention is screening for early diagnosis and treatment for precancerous cervical lesions by method of the pap smear and cervical cytology. This service is offered free of charge to eligible and high-risk patients. So what is cervical cancer? In the cervix, we have the squamocolumnar junction, which is where the ectocervical squamous epithelium and the endocervical columnar epithelium join. In young, healthy women, the exposed parts of the endocervical cells are replaced with squamous cells in a metaplastic process. This area is called the transformation zone. Within this zone, there's high mitotic activity, which leaves these cells sensitive to carcinogens, and they can become dysplastic, which eventually can lead to cancer. There's just a little picture of where the transformation zone is. So our risk factors for cervical cancer is most importantly HPV, which is the most common cause of cervical cancer and is a sexually transmitted virus. 99% of cervical cancers are associated with HPV. HPV 16 and 18 especially are oncogenic. There are others as well, and places the patient at high risk for cervical cancer, especially in cases of persistent infection. Young age of coital and multiple sexual partners place women at an increased risk of HPV. HIV is a risk factor for cervical cancer as it increases the risk of persistent HPV infections. And the National Department of Health calls this the dual epidemic. Smoking is a risk factor, and women of all ages should be encouraged to stop smoking. Smoking decreases the immunity and decreases clearance of HPV, which leads to a persistent HPV infection. And a woman who smokes is then twice as likely to develop cervical CA. Hormonal contraceptives place women at a slight increased risk. However, it has more to do with a combined set of risk factors, including their sexual behaviors. If you are on a hormonal contraceptive, for example, you'd be less likely to use a condom, and then you can still contract HPV. Symptoms to suggest cervical CA. These are not the only time you do a pap smear, but they can also guide you towards doing it. And abnormal vaginal bleeding, which is not associated with your menstrual bleeding. Vaginal discharge, unresolving lower abdominal or vaginal pain, dyspareunia and bleeding during intercourse, lower urinary tract symptoms like dysuria and urinary frequency, and postmenopausal vaginal bleeding. So how do we know who needs to get a pap smear and how often and when? So the National Department of Health guidelines suggest that every low risk, which is an HIV negative woman, should be offered a pap smear at the ages of 30, 40, and 50 years old, which equates to 3 per lifetime at 10 yearly intervals. And these are all free, or they should be free at the primary healthcare level. The revised guidelines suggest that HIV positive female patients receive a pap smear at the time of their HIV diagnosis. And then if they have an abnormal result, it should be 3 yearly. It would also depend on what the result is, which we'll get into later. But if it's a normal result, then they can go on to receive 10 yearly smears. So how do we perform a pap smear? So you would insert the speculum and visualize the cervix. When you visualize the cervix, you also need to look for any cervical abnormalities, for example, masses, polyps, ulcers, erosions. If the cervix is bleeding, it should be cleaned with a swab to reduce the blood in the specimen. If a patient is menstruating, you would actually defer the pap smear. But if she is just having vaginal bleeding as a part of a symptom, then you would clean the cervix and go ahead with the pap smear. Previously, an endocervical brush was used to sample cells from the endocervical component, and it's in this little picture that you can see over here. And an ectocervical spatula was used to obtain cells from the ectocervical component. The specimen was then fixed on a glass slide and sent for cytology. We don't really use those anymore. I haven't used it since I was a student, and we now use the cervical broom, which allows sampling from the ecto and endocervical components together. The broom needs to be turned clockwise and then anti-clockwise several times, and then the tip of the broom is removed from the stick and placed securely in the medium bottle, which we usually get filled with medium and prepackaged. An adequate cervical sample contains ecto and endocervical cells. You need at least 10 endocervical cells and or squamous metaplastic cells on a slide. And then we need to see 8,000 to 12,000 cells per slide, while less than 75% of the slide should be obscured by inflammatory or blood cells. And that's why it's important to clean the cervix from any blood before you do the pap smear. So we have a little video here. I just want to see if we can play it. I'm not going to do the whole video. I'll just do the part where they do the pap smear so that we don't waste time. Okay, so in the interest of time, we'll just stop it there. So yeah, just a picture. So what do we look for when we actually do the pap smear? On the results, we'll look for LSIL, which is low-grade squamous intraepithelial lesion, which may suggest CIN1. We can also get HSIL, which is a high-grade squamous intraepithelial lesion, which may suggest CIN2 and 3. We can get atypical squamous cells of uncertain significance, and we can get atypical squamous cells where HSIL cannot be excluded. Those are the squamous abnormalities. We can also get glandular abnormalities, which are adenocarcinoma in situ, atypical glandular cells, and atypical glandular cells not otherwise specified. And you would usually wait about 6 weeks to get your pap smear results. So that's when you would tell your patient to come back. This is just a picture showing how it would look, depicting the changes. And then once you get the results, how do you know what to do? So in patients with an index episode of low-grade squamous intraepithelial lesion, of atypical squamous cells of unknown significance, and the agnos, you would repeat the smear after 1 year before you would refer them. If patients have recurrent ulcer, so if you repeat the smear after a year and they have ulcer again, then you would refer them. Or if they have HSIL, ASCH, which is the atypical squamous cells, but you cannot exclude high grade, the adenocarcinoma in situ, then you would refer them for colposcopy by a gynecologist. And this picture is just showing how they would actually end up doing the colposcopy by staining with Lugol's iodine and seeing where they actually need to take the sample from. So this is not my table, I didn't make it. It's a table from the National Guidelines on Cervical Screening that I mentioned earlier. And this is how they suggest follow-up for the results. So like I said, the ascus, the ulcer, those you would repeat after 1 year. And then after 3 years, you would repeat in HIV positive women if they have an ulcer. And then the ones that you would refer would be the ASCH, the HSIL, the carcinomas, the malignancies. Those you would refer immediately for colposcopy. And then this is just a summary of the process. And we thank you. And our resource list. We're done.
Thank you very much. Really appreciate that. Any comments from anybody about the presentation or any additional comments? Please pick up your hand. In the meanwhile, I think this great work. Thank you very much. You guys all been presenting, do a great job trying to provide the learning, and I think everyone appreciates it. We certainly do. Just a key comment. Both these problems are actually big problems in primary care. In the Joburg district, for example, contraception uptake is not as good as it should be. And one of the problems is that, and both of them as well. In the contraception, a big problem is the fact that a lot of the nurses at facilities are not using they're resorting to the injectable too easily. Some of them are using the implants, but the IUCDs are not done. And I think there's a lot of reluctance around it. Some people might complain that they don't have the right tools, particularly whether the actual devices, IUCDs, or the simple things like specula, etc. So I think that there's a serious problem with that. Same problem exactly with regards to nurses who are not doing pap smears often enough. And both these have been bad and have been worsened over with the COVID pandemic. And one of the things that as a Department of Family Medicine, we've said we need to focus on is getting these two things done. So the next group of interns will be part of a quality improvement project, something we haven't been able to do well enough with you as a group, but that we're looking to ensure we include in the next round with new interns coming from July. So thank you once again. I think all the resources that you put out is certainly helpful and will certainly hopefully help us to improve the quality of training of your colleagues who join us in the next run. Any other comments, questions? It seems the next group, I've been just received an apology that they got themselves mixed up, and that we will see if we can include them in another session in the next 1 or 2 weeks left in your block. So with that, I don't know if there are any other comments. Please send me the slides. We will actually include them into the recording that we